All right. So welcome everyone to this month's DUR meeting. My name is Luis Moreno, pharmacist with Utah Medicaid. And just a few reminders for our meeting today. If you are dialing via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DUR board members, please reserve questions until the end of presentations or ask in the Google Meet chat. And those of you with public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicaidpharmacy@utah.gov. Also, attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicaidpharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process moving forward. And thanks for that. All right, so now we have the agenda, and the first order of business is the approval of the pending January DOR board meeting. And let's see here. And I will share those for your convenience. And so, yeah, do I have a motion for to approve the minutes?
I'll motion. This is Laura Britton.
I'll second.
All right. Thank you so much, Laura Brinton and James Keddington, for those motions. And also, all in favor?
Aye.
Aye.
Thank you. Any opposed? And any abstentions? All right, so the motion passes to approve the January DUR board meeting minutes. Thank you for that. And also, I did forget to mention, so our former DUR board manager, Dr. Stephanie Byrne, has accepted a position at the 4th Street Pharmacy, and we wish her well. And so because of that change, I have accepted the role of DUR board manager. And so I will be conducting today's meeting as well as next month's meeting. And then our board chair, Dr. Sharon Weinstein, will resume conducting the meetings starting in April. All right, and so now I'd like to turn the time over to Dr. Nguyen with the P&T update.
Good morning. For P&T, next week will be the first P&T meeting of the year. We are going to review the EGFR inhibitor for approved oncology disorder, and we'll report back to the DUR board afterward. That's all for the P&T update.
Excellent. Thank you, Dr. Nguyen. And now I'm pleased to turn the time over to Dr. Lulo with the DRRC for the presentation on the CAR-T therapies.
Okay, thank you so much. Everyone should be able to see those slides. Good morning. I have quite a bit to cover this morning, so just go ahead and get started. Today, I'll be discussing key considerations for the use of select chimeric antigen T-cell therapies, abbreviated CAR-T, including axicabtagene ciloleucel, brexacabtagene autoleucel, lysocaptogene maralocel, and obacaptogene autolocel, which I'll refer to as axicel, bruxacel, lysocel, and obacel respectively. Additionally, as relevant throughout the presentation, I'll briefly touch on another CD19-directed CAR-T product, tisagenlecleucel, which I'll refer to as Tisacel. For the sake of time, I will not be reviewing background information on the indicated disease states for these CAR-T therapies. Please refer to the report for these details. CAR-T therapies are cell-based immunotherapies that offer targeted treatment options for patients with certain hematologic malignancies. CAR-T therapies are produced ex vivo by genetically modifying the patient's own T cells to express a particular receptor that targets a tumor-associated antigen. Axicel, bruxacel, lysocel, and obacel all target CD19 on B cells that are approved as a one-time treatment course. Following CAR-T administration, the genetically modified T cells proliferate upon encountering CD19 expressing cells and destroy these cells through immune-mediated mechanisms. Altogether, the general approved indications encompass several relapsed or refractory B-cell cancers, including large B-cell lymphoma, or LBCL, follicular lymphoma, or FL, mantle cell lymphoma, or MCL, B-cell precursor acute lymphoblastic leukemia, or BALL, and chronic lymphocytic leukemia, or CLL, or small lymphocytic lymphoma, or SLL. All indications across these agents are specific to adults only, except Tisacel's indication for BALL, which is for pediatric and young adults up to 25 years of age. While the general indicated conditions for some reviewed CAR-T agents overlap, the full FDA indications may not overlap completely. Both bruxacel and obacel are approved for relapsed or refractory BALL, whereas Tisacel is approved for refractory disease or for second or later relapse. While bruxacel and lysocel are indicated for relapsed or refractory MCL, lysocel is more specifically indicated after 2 or more prior lines of therapy that included a Bruton tyrosine kinase or BTK inhibitor. In the setting of LBCL, axicel and lysocel indications differ with respect to the patient population and indicated LBCL subtypes as shown on the next slide. Both axicel and lysocel are approved for LBCL that is either refractory to first-line chemoimmunotherapy or that relapses within 12 months of first-line chemoimmunotherapy or after 2 or more lines of systemic therapy. Lysocel is also approved for LBCL that is refractory to or relapsed after first-line chemoimmunotherapy in patients who are ineligible for hematopoietic stem cell transplantation or HSCT because of age or comorbidities. While the labeled indication for axicel does not specify particular LBCL subtypes in the setting of relapsed or refractory disease to first-line chemoimmunotherapy, specific LBCL subtypes are specified in the setting of relapsed or refractory LBCL after 2 or more lines of systemic therapy, including diffuse large B-cell lymphoma, abbreviated DLBCL, not otherwise specified, DLBCL arising from FL, primary mediastinal large B-cell lymphoma, abbreviated PMBL, and high-grade B-cell lymphoma, abbreviated HGBL. Specific LBCL subtypes are included in the labeled indication for lysocel, which pertain to each LBCL indication. The labeled indication for lysocel, but not for axicel, includes FL grade 3B, which is an aggressive type of FL and has similar characteristics to DLBCL. Additionally, lysocel is broadly approved for relapsed or refractory DLBCL arising from an indolent lymphoma, whereas axicel labeling specifies DLBCL arising from FL in one of the LBCL indications. Yet the wording for the other LBCL indication for axicel is general to LBCL, appearing to not restrict by LBCL subtypes. Dosing for the reviewed CAR-T products is either wave-based, as with axicel and bruxacel, or fixed dose, as with lysocel and obacel. For bruxacel and lysocel, the recommended target dose or dosing range varies depending on the indication and our prior treatment status. Axicil, Bruxicil, and Lysicil are given as a single IV infusion, whereas Obicil is administered as 2 separate IV infusions approximately 9 days apart. Axicil, Bruxicil, and Lysicil administration must occur at Risk Evaluation and Mitigation Strategy or RIMS certified treatment centers. Obicil does not have a RIMS requirement. RIMS certified centers are required to register and guarantee access to at least 2 doses of tocilizumab. Prescribing information for Obicil advises that it be administered in a setting with immediate access to cytokine release syndrome treatments, including tocilizumab. Treatment centers for Obicil must also certify with the manufacturer to dispense it. The procedures for preparation of Axicil, Bruxicil, Lysicil, and Obicil are highly medically intensive and require multiple steps over weeks to months. First, leukapheresis must be performed to collect white blood cells, which are sent to the CAR T products manufacturing site. Some patients may receive bridging therapy with other treatments to maintain disease control while waiting for their CAR T product to be manufactured. Before the CAR T products can be infused, patients must undergo a 3 or 4-day course of low-dose lymphodepleting chemotherapy to make space for CAR T expansion and persistence once infused. Additionally, for Obicil, a bone marrow assessment should be obtained within 7 days before starting lymphodepleting chemotherapy to determine the appropriate Obicil dosing regimen. Patients should be pre-medicated with acetaminophen and or diphenhydramine or an alternative H1 blocking antihistamine 30 or up to 60 minutes prior to the CAR T infusion to minimize the potential for infusion reactions. Prophylactic corticosteroids should be avoided with Bruxicil, Lysicil, or Obicil, as they may interfere with product activity, but may be considered after assessing the benefits and risks in patients undergoing treatment with Axicil. After administration of these products, patients are required to have daily or more frequent monitoring at the treatment center for a minimum of 7 or 14 days for the development of neurotoxicity, cytokine release syndrome, or other acute toxicities. Patients should remain in close proximity to the healthcare center for at least 4 weeks post-infusion to allow for continued monitoring. Patients should also, Patients should also refrain from driving for at least 8 weeks after receiving the CAR T infusion, given the risk of seizures, decreased consciousness, among other neurologic events. To summarize CAR T place in therapy, we reviewed various guidelines from the National Comprehensive Cancer Network, abbreviated NCCN, as shown on this slide. Overall, NCCN guideline recommended uses generally align with their respective FDA indications. We infer that the recommendations from reviewed guidelines are primarily for adults. Separate pediatric NCCN guidelines were reviewed for aggressive mature B-cell lymphomas and BALL. In the setting of DLBCL, Axicil and Lysicil are recommended both as Category 1 for eligible patients who relapse within 12 months of first-line therapy or who have primary refractory disease. Lysicil as Category 2A is among preferred options for patients who are not planning to undergo a stem cell transplant or HSCT and who relapse more than 12 months after first-line therapy. CAR T therapy with Axicil, Lysicil, and Tizicil is a consolidation therapy option, among others, for patients with a partial response to second-line therapy intending to proceed to HSCT who relapse more than 12 months after first-line treatment. If not previously tried, Axicil, Lysicil, and Tizicil are preferred third or later line options. Notably, the NCCN recommends managing relapsed refractory HGBL according to the algorithm for DLBCL. Additionally, NCCN recommended treatment options for relapsed refractory PMBL include immunotherapy-based regimens or the same options that apply to relapsed refractory DLBCL. Thus, CAR T therapy with Axicil or Lysicil are second-line therapy options for eligible patients, and Axicil, Lysicil, and Tizicil are preferred third-line or subsequent therapy options if not previously tried. In the setting of histologic transformation of indolent lymphomas to DLBCL among patients with no or minimal prior therapies for the indolent lymphoma, CAR-T therapy with oxacil, lysacil, and tizacil are a second-line option after at least one anthracycline-based regimen, unless contraindicated, for patients with either no response or positron emission tomography positive disease with a partial response to or progressive disease after first-line therapy. Among patients who receive 2 or more chemoimmunotherapy regimens for indolent disease, CAR-T therapy with oxacil, lysacil, or tizacil is a preferred second or subsequent line option, if not previously given, for patients who have positron emission tomography positive disease with a partial response to first-line or prior therapy for DLBCL and have received at least one prior anthracycline-based regimen, unless contraindicated. FL is histologically classified according to 3 grades. Grades 1 through 3A are associated with slower growth and are treated as classic FL, whereas grade 3B is a faster growing form of FL and is often treated like DLBCL. In the setting of classic FL and pediatric type FL in adults, which is another distinct type of FL, NCCN reserves oxacil, lysacil, and tizacil as third or later line preferred treatment options. Grade 3B FL should be treated according to recommendations for DLBCL. Thus, oxacil and lysacil are among second line therapy options, and oxacil, lysacil, and tizacil are among third or subsequent line treatment options if not previously given. In the setting of relapsed refractory MCL, NCCN recommends CAR-T therapy with broxacil or lysacil as consolidative therapy or subsequent therapy for patients with no response or progressive disease on second-line therapy, including covalent BTK inhibitor regimens, or as a less preferred option for patients with a partial response to second-line therapy with fixed duration chemoimmunotherapy regimens or involve site radiation therapy or ISRT. Broxacil and lysacil are also recommended as third or later line options for patients who progressed after prior covalent BTK inhibitor therapy for relapsed or refractory disease and have not previously received CAR-T therapy. CAR-T therapy with broxacil, obe-cel, and tizacil is among NCCN recommended options for second line or subsequent therapy for relapsed or refractory Philadelphia chromosome positive or Philadelphia chromosome negative BALL. NCCN recommendations for the use of these CAR-T agents vary by Philadelphia chromosome status. Broxacil, obe-cel, and tizacil are among second-line or subsequent therapy preferred options, among others, for Philadelphia chromosome negative BALL. Broxacil, obe-cel, and tizacil are also among options designated as other recommended for relapsed or refractory Philadelphia chromosome positive BALL after tyrosine kinase inhibitor, abbreviated TKI, therapy. Notably, the recommendations for tizacil are more restrictive than for broxacil and obe-cel. Tizacil is recommended for patients less than 26 years old who have refractory BALL or who have experienced 2 or more relapses, and in the setting of Philadelphia chromosome positive BALL, patients must have previously tried 2 TKIs. In the setting of relapsed refractory CLL or SLL, the NCCN recommends lysacil as a preferred option after treatment with a BTK inhibitor and venetoclax, a BCL2 inhibitor-based regimen. CLL or SLL transformation to clonally unrelated DLBCL is recommended to be treated using the same approach as for de novo DLBCL or participation in a clinical trial. For patients with clonally related or unknown clonal status at CLL or SLL transformation that is refractory to chemoimmunotherapy or with DEL17P or TP53 mutation, a clinical trial is the preferred approach, but other options include CAR-T therapy with lysacil, immune checkpoint inhibitors, and or BTK inhibitors, or managed as recommended for DLBCL. The NCCN recommends Axicell off-label as a preferred third-line and subsequent therapy option for marginal zone lymphoma based on positive results from the ZUMA-5 trial. Except for Tizicell, none of the reviewed CAR-T products have approvals in the pediatric population. Yet the NCCN provides CAR-T treatment recommendations for pediatric patients in the setting of PMBL and BALL. For relapsed or refractory PMBL, the use of CAR-T therapy with Axicell or Lysocell is recommended as a consolidation therapy in patients who achieved a partial response to an induction regimen, provided they have received 2 or more prior chemoimmunotherapy regimens. This recommendation is based on data extrapolated from adults with relapsed or refractory PMBL. For the treatment of pediatric BALL, Tizicell is the only CAR-T product among recommended options, which include both on-label and off-label uses as part of first-line therapy or for relapsed or refractory disease. See page 41 of the report for specific recommendations. Pivotal clinical trials supporting FDA approval for Axicell, Bruxicell, Lysocell, and Obicell were all open-label studies in adults. Most were early-phase single-arm trials. However, 2 phase 3 randomized controlled trials, or RCTs, have been conducted in the setting of relapsed or refractory LBCL. In the phase 3 RCTs for LBCL, ZUMA-7, and Transform, Axicell or Lysocell respectively were evaluated as second-line therapy compared to standard of care chemoimmunotherapy regimens in patients with primary refractory or early relapse LBCL. Axicell and Lysocell have also been studied in single-arm trials among more heavily treatment-experienced adults with relapsed or refractory LBCL. All trials required participants to be previously treated with first-line therapy that included an anti-CD20 monoclonal antibody and an anthracycline. Both RCTs achieved their primary endpoint in the intention to treat population, demonstrating significantly improved event-free survival with Axicell or Lysocell compared to standard of care chemoimmunotherapy. The median event-free survival was extended by about 6 months with Axicell and is still in development for Lysocell. Both Axicell and Lysocell have been studied for the treatment of relapsed or refractory FL grade 1 to 3A in 1 single-arm pivotal clinical trial each. All participants were required to have prior treatment with an anti-CD20 monoclonal antibody in combination with an alkylating agent. The primary endpoint in both trials for overall response rate was 94% with Axicell at a median follow-up of 17.5 months and 97% with Lysocell at a median follow-up of 18.9 months. The median duration of response was not reached for either Axicell or Lysocell. In the setting of relapsed refractory MCL, Bruxicell and Lysocell have each been studied in a pivotal single-arm trial. Both trials required prior treatment with a BTK inhibitor, plus various other treatments which varied by trial. The percentage of treated participants among the primary analysis set who achieved the primary endpoint of an objective response at a median follow-up of approximately 12 or 16 months, depending on the trial, was 93% with Bruxicell and 86.5% with Lysocell. 2 pivotal single-arm trials, ZUMA-3 and Felix, studied Bruxicell and Obicell respectively in the setting of relapsed or refractory BALL. Both trials met their primary endpoint with around 70% of treated patients achieving overall remission at a median follow-up of approximately 16 or 20 months, depending on the trial. In the setting of relapsed refractory CLL or SLL, Lysocell was studied in a pivotal single-arm clinical trial. Eligible patients had to previously fail or be ineligible for BTK inhibitor therapy and had to receive at least 2 or 3 prior lines of therapy, depending on risk features. Treatment with Lysocell achieved a complete remission or response rate of 18% among patients in the primary efficacy analysis set who had prior disease progression on a prior BTK inhibitor and venetoclax failure. Overall response rate, a key secondary outcome, was 43% in the primary efficacy analysis set. While the median duration of follow-up was not reported for the primary efficacy analysis set, it was approximately 20 months in the entire study population. Currently, evidence from pivotal clinical trials supports using Axicel, Broxacil, Lysacil, and Obacil as a one-time treatment, as pivotal trials for these agents generally excluded patients previously treated with CAR-T therapy and or CD19-directed therapy. While many of the pivotal clinical trial protocols for Axicel, Broxacil, and Lysacil mentioned allowing retreatment with the same CAR-T product for patients who relapsed after responding to the initial CAR-T treatment, published results from retreatment are very limited across trials. Overall, when reported, results from some studies show complete response rates ranged from 12.5 to 22% in different trials for LBCL. Uniquely, 100% of Axicel retreated patients with either FL or marginal zone lymphoma who experienced subsequent relapse after response to the initial Axicel infusion responded to a second Axicel infusion. 77% achieved a complete response and 46% had an ongoing response after a median follow-up of 11.4 months. The reviewed NCCN treatment guidelines do not make a formal recommendation in favor of retreatment with the same or different CAR-T agent. In fact, there are several scenarios where the NCCN states that CAR-T is recommended only if it has not been previously used, such as for third or subsequent line therapy for certain LBCL subtypes and for marginal zone lymphoma. There are no contraindications to Axicel, Broxacil, Lysacil, or Obacil therapy. Nonetheless, these therapies are associated with serious and potentially life-threatening adverse events. Generally, Axicel, Broxacil, Lysacil, and Obacil carry the same labeled warnings, including black box warnings for cytokine release syndrome, neurologic toxicities, and secondary T-cell malignancies. Axicel, Broxacil, and Lysacil also require a REMS program. Other warnings or precautions are regarding hypersensitivity reactions, prolonged cytopenias, severe infections, hypogammaglobulinemia, and that patients should avoid driving or using heavy machinery for at least 8 weeks after the CAR-T infusion. Broxacil, Lysacil, and Obacil also carry warnings or precautions for rare but potentially life-threatening immune-related conditions. While Axicel does not carry a labeled warning for such conditions, events were observed during clinical trials. The DUR board may consider the information highlighted on the next couple of slides to guide the development of drug-specific prior authorization criteria for Axicel, Broxacil, Lysacil, and Obacil, along with details elaborated in Section 10 of the report. We recommend requiring that patients be at least 18 years of age and meet the FDA-approved indication and/or NCCN guideline recommendations based on provider attestation and our clinical documentation. NCCN recommendations that expand upon the FDA-labeled indication are highlighted in blue font on the slide. It is possible that NCCN recommendations include additional scenarios that are beyond the specific FDA-approved indications, which could be considered on a case-by-case basis, provided the guideline recommendation and evidence base are in support of use. I will highlight some of the considerations based on NCCN recommendations. In the setting of LBCL, that is refractory or relapsed or refractory after 2 or more lines of systemic therapy, we suggest that Axicel be allowed for DLBCL that transformed from other indolent B-cell lymphomas in addition to FL transformation. This is in line with the NCCN guideline recommendations supporting the use of Axicel for DLBCL transformed from indolent lymphomas. Additionally, Axicel could be considered for later line treatment of marginal zone lymphoma as recommended by the NCCN, although the FDA has not yet granted approval for this indication. In addition to meeting the FDA-approved indication for Broxacil in the setting of relapsed or refractory MCL, it is reasonable to require that patients previously received or be inappropriate for BTK inhibitor therapy or be intolerant to such therapy, which is in line with the NCCN recommendations and the pivotal clinical trial. Additionally, patients with Philadelphia chromosome positive BALL may be required to receive at least one TKI or be inappropriate for such therapy before proceeding to Bruxisel as recommended by the NCCN. The Bruxisel pivotal trial for BALL required Philadelphia chromosome positive BALL patients to be intolerant to TKI therapy or to be relapsed or refractory despite treatment with at least 2 different TKIs. For Lysocell, we recommend that patients meet one of its labeled indications. For Obicell, in addition to meeting the FDA-approved indication for relapsed or refractory BALL, we suggest that patients with Philadelphia chromosome positive BALL also be required to have previously received at least one TKI or be inappropriate for such therapy as recommended by the NCCN. Although such criterion would be more specific and potentially more restrictive than the labeled indication, it is consistent with the inclusion criteria for the Obicell pivotal trial Felix. If desired, additional PA criteria based on provider attestation or clinical documentation could also be considered, such as those listed here. To highlight a couple of ideas, you may consider having the prescriber attest that the patient does not have a clinically significant active infection and has counseled the patient about the potentially serious adverse effects that have labeled warnings. Thank you for your time and attention, and please let me know if you have any questions.
Thank you, Dr. Lulu, for that comprehensive presentation. It's exciting new things and definitely complex therapies here. And so now I'd like to open up to the DURB board if they have any questions for Dr. Lulu. Yes, Dr. Brinton.
I didn't have any questions, but I did want to compliment the state on those criteria. They were well written, and we appreciate them.
Thank you. All right, so now I'd just like to say a quick reminder for those attendees that are not members of the DURB board, please enter your contact information in the Google Meet chat. That way we can put those in the minutes for this meeting. And now we have two people here providing public comment. And again, the public comment is limited to 3 minutes. And so Dr. Wen is going to keep track of those minutes for us today. First, we'll hear from Dr. Keith Huff, representing Bristol Myers Squibb, regarding Abecma. Go ahead, Dr. Huff.
I believe you're muted, Dr. Huff.
Let's see, Dr. Huff, are you still here with us? You might be muted. Let's see here. It says, I tried to unmute him, but it says you can't unmute someone else. But yeah, the mute button is going to be towards the left-hand side, down at the bottom of the screen. Have you located that one, Dr. Huff?
Do you want to maybe hang up and then come back, see if it's work? And in the meantime, we can move on to the next person and then come back to Dr. Huff after.
Sounds like a viable suggestion there. Given that we are need to make good use of our time now. So we'll go ahead and do that then. We'll see if we can hear from Dr. Amy Hale then, representing J&J regarding CAR T therapy, Carvykti.
Good morning. I do want to ensure this is the appropriate time to speak since this is a BCMA-directed CAR T therapy and not based on the previous presentation.
Oh, yes. Yes, go ahead, Dr.
Okay,
Hale.
great. Thank you. Hello, all. My name is Amy Hale, and I'm a pharmacist and principal scientific account lead at Johnson & Johnson Innovative Medicine. I want to thank you for the opportunity to speak to you this morning about Carvykti, or siltacabtagene autoleucel, which I will also refer to as Cilta-cel. Carvykti is a BCMA-directed genetically modified autologous T-cell immunotherapy approved for the treatment of adult patients with relapsed or refractory multiple myeloma who've received at least one prior line of therapy, including a proteasome inhibitor and an immunomodulatory agent, and are refractory to lenalidomide. Carvykti includes a box warning regarding the occurrence of cytokine release syndrome, or CRS, neurologic toxicities, HLH and MAS, prolonged and recurrent cytopenias, and secondary hematologic malignancies. Carvykti is only available through the Carvykti REMS program. It comes as a cell suspension provided as a single dose for IV infusion containing a target dose of CAR-positive viable T cells. So CARTITUDE-4 is an ongoing phase 3 randomized open-label study evaluating the efficacy and safety of a single Cilta-cel infusion versus physician's choice standard therapy after 1 to 3 prior lines of therapy. All percentages noted today are rounded to the nearest whole number unless otherwise stated. The median progression-free survival was not reached in the Cilta-cel arm and was 11.8 months in the standard therapy arm. The 12-month PFS rates for Cilta-cel and standard therapy were 76% and 49% respectively. Treatment discontinuation was reported in 63% in the standard therapy arm. 56% of those were due to disease progression. Overall response was 85% in the Cilta-cel arm versus 67% in the standard therapy group. Complete response or better was 73% for Cilta-cel and 22% for standard therapy. And an absence of minimal residual disease, or MRD negativity, was achieved in 61% of Cilta-cel patients versus 16% receiving standard therapy. Grade 3 or 4 adverse events occurred in 97% of Cilta-cel patients and 94% of those receiving standard therapy. Serious adverse events were reported in 44% receiving Cilta-cel and 39% receiving standard therapy. Infections of any grade occurred in 62% of Cilta-cel patients and 71% of standard therapy patients. Secondary primary malignancies were reported in 4% of Cilta-cel patients and 7% of those receiving standard therapy. Death of any cause was reported in 39 Cilta-cel patients and 46 standard therapy patients. CRS was reported in 76% of Cilta-cel patients and was mostly grade 1 or 2 with a median time to onset of 8 days and median duration of 3 days. All cases resolved. A total of 4.5% of patients experienced ICANS, and all were grade 1 or 2 with a median time to onset of 10 days and duration of 2 days. Cranial nerve palsy of any grade was reported in 9% of patients and 1% were grade 3 or 4. CAR T-related peripheral neuropathy of any grade was reported in 3% of patients and 1 patient had grade 3 or 4. Finally, movement and neurocognitive treatment emergent AEs of any grade were reported in 1 patient, and there were no fatal neurotoxicities. As described, the use of Carvykti demonstrated a significant reduction in the risk of disease progression or death versus standard therapy. I would like to respectfully ask the Utah DUR board to consider no prior authorization restrictions for Carvykti, and I'm very happy to answer any questions you may have, and I want to sincerely thank you again for your time this morning.
Thank you so much, Dr. Hale, for your information on this CAR T therapy. And let's see, now we'll ask Dr. Huff if he's able to provide testimony now. And he might not be with us anymore. All right. Okay, so now we will move on in the interest of time to the presentations of each of the prior authorizations that were prepared. So we'll start with, oh, go ahead, Dr. Siegfried.
Thank you. I just wanted to clarify on slide 19 of 37, since we are using NCCN guidelines in some cases, Axicel and Lysocel are recommended as consolidation therapy in pediatric patients. under the age of 18, and all of our PA criteria forms are for adults only. How would that be handled from the side of the clinician in terms of requesting those medications for those under the age of 18?
So to clarify, based on the current criteria that we've come up for these therapies, Dr. Siegfried is saying that they're only aimed at the treatment of adults with these conditions and not pediatric patients at this time. Is that correct, Dr. Siegfried?
Yes, I just want to ensure that, even if the PA criteria remain for patients 18 years and older, that there is, a way that providers can still get Axicel or Lysocell for consolidation therapy for pediatric patients in a timely manner, given that these therapies take a long time to be prepared and administered. For consolidation therapy in relapsing or refractory PMBL based on NCCN guidelines.
All right. So thank you for that, for pointing that out. And so we do have off-label criteria where the provider can submit in case the agent is being used off-label. And that is part of our medication coverage exception form. But Dr. Siegfried, would you rather that also be added to the PAs for these agents, just so it's more clear?
I would
pass-through
actually
coverage?
defer to the board's decision on, because they're already quite complicated forms, but I just want to ensure that, it wouldn't get kind of buried and that there would be a very quick turnaround given the, lengthy time that these therapies require to be prepared before they can be administered to the patient, was my main concern.
All right. Thank you for that suggestion. So, Dr. Brinton, you raised your hand.
Yeah, I was just going to say, at least for the ACOs, there's very specific turnaround times that we're required to meet, regardless of whether our request is, meets the criteria or not. And so anything that's off-label or that would be, not part of the criteria would be reviewed for medical necessity. And it would be turned around in the same amount of time that anything else would be.
Yes, and I would add, that we have the same process at Utah Medicaid.
Okay, thank you.
Thank you, Dr. Siegfried. All right, so now we'll move on to the presentation of BECMA and also CARVICTI for our criteria for Utah Medicaid, and that will be by Dr. Park.
Thank you, Luis. Okay, let me share my screen. Okay, do you guys see my screen okay? Okay, perfect. So the first presentation is for ABECMA, and then we made a few edits since sending out the previous draft. So the first criteria is the patient is 18 years of age or older. And then the second one is the diagnosis of the relapsed or refractory multiple myeloma. And the third one is being prescribed by or in consultation with oncologist or hematologist. And the last one is the previous treatment with at least 2 lines of systemic therapies with immunomodulator, anti-CD38 monoclonal antibody, and proteasome inhibitors. Okay, any suggestions or comments on this one? Oh, yes, Dr. Burton.
I was just curious what changes were made since the last time it was sent out. Is that what you were
Oh, yeah.
noting?
Oh, yeah. Yeah, I can definitely go over the changes. Okay, so this is the previous draft. So basically, we removed the we modified the criteria number 4 because receiving 2 to 4 systemic therapies with agents from each of the following categories, it can be quite ambiguous. It can be understood as like 2 to 4 agents from each categories. So to eliminate those confusing, we modified to like we made it like much simpler and then more straightforward with this one. Okay. Any more comments? Okay, and then I'll move on to the next one. This is the CARVYKTI.
Sorry, Ashley.
Yeah.
We need the motions.
Oh yeah, sorry.
All right, thank you for that, Noon. So do we have a motion to approve the criteria as presented for BECMA?
So move.
Thank you, Dr. Brinton. Can I get a second?
I can second. This is Laura Britton.
Thank you, Dr. Britton. All in favor?
Aye.
Aye.
Any opposed? Any abstentions? All right, motion passes to approve the criteria as presented for a BECMA. And now we'll allow Dr. Park to continue with the next CAR T therapy, CARVYKTI.
Okay, thank you so much, Dr. Moreno. Okay, so also for this one, we made a few edits since sending the last draft. The first one is age requirement of 18 years or older. And the second one, the diagnosis of relapsed or refractory multiple myeloma. And the third one is being prescribed by or in consultation with oncologist or hematologist. And the fourth one is receiving at least 1 line of systemic therapy with immunomodulatory agent, proteasome inhibitor, and is refractory to lenalidomide. And then the last criteria is this one is only applicable for the first relapse or refractory to the first line of the therapy. And then for those, this will require more aggressive disease defined as disease progression within 36 months of the stem cell transplant or 42 months of starting the initial treatment. Okay, any questions or comments? Yes, Dr. Burton?
I just want to ask on number 4 why it was reduced to 1 line of systemic therapy and the prior version had 2 to 4 systemic therapies.
Oh, this is like this is based on the FDA indication. So for the abecma, it requires at least 2, and then for CARVYKTI can be used for the first relapse or refractory. So yeah, this is all based on the FDA indication.
Is that also what is supported by NCCN?
Yes.
Okay.
Okay, any other questions?
Thank you, Dr. Park. And do we have a motion to approve these criteria as presented?
Motion to approve, Sam.
Thank you so much. Can I get a second?
I will second that, Dr. Siegfried.
Thank you, Dr. Siegfried. And all in favor?
Aye.
And any opposed? Or any abstentions? Motion passes to approve this criteria as presented for CARVYKTI. Thank you so much. And now we'll give the time to Dr. Nguyen to present on the following 2 PAs, the Yescarta, and then also for the gene therapy, Nenmeldi at this time.
Thank you, Lee. So this is the proposed criteria for Yescarta. All of the following criteria must be met. Is the patient 18 years of age or older? Does the patients have diagnosis or relapse or refractory large B-cell lymphoma or relapse or refractory follicular lymphoma? The patients does the patient has the central nervous system lymphoma? Is the medication being prescribed by or in consultations with an oncologist or hematologist? Has the patient experienced one of the following for LBCL? Do the patient have relapse within 12 months or refractory to first-line systemic therapy? Or if they are relapsed or refractory to 2 or more lines of systemic therapy? For follicular lymphoma, does the patient have relapse or refractory to 2 or more lines of systemic therapy, and list those therapy out? This is a one-time authorizations. And these are some notes for the warnings of the Yescarta. Cytokine release syndrome, including fatal or life-threatening reactions, occur in patients receiving Yescarta. Do not administer to patients with active infections or inflammatory disorder. Treat severe or life-threatening CRS with tocilizumab and corticosteroid. Neurotoxic toxicity warning. T-cell malignancy also a warning, and Yescarta is available only through a RAM program and our billing guidance. It's just some brief modified versus the draft that we're sending out to the board. Any questions, comments?
Yes, Dr. Lulo?
I just had a quick comment on the patient not having primary central nervous system lymphoma. I just noticed that it says all the criteria has to be met up at the top. So I'm not sure if that question needs to be rephrased, because the patient should not have that because it's not indicated for that condition. So I just wanted to point that out because I don't think I touched on that during the presentation. So
Thank you. Yes, that was rephrased just a second ago. So thank you for pointing that out. Any other comments on the PA?
All right, can I get a motion for approval of the criteria as presented for Yescarta?
I'll motion. This is Laura Britton.
Thank you, Dr. Britton. Can I get a second?
Second.
Thank you, Dr. Franciski. And all in favor?
Aye.
Any opposed or any abstentions? All right, thank you. Motion passes. And now we'll move on to our last PA criteria presentation for Lenmeldi.
This is the proposed criteria for Melody. Criteria for approval is the patient 18 years of age or younger. Is the medication being prescribed by or in consultation with the neurologist specialized in the treatment of metachromatic leukodystrophy? Does the patients have the re-symptomatic or early symptomatic of any of the following diagnoses, such as late infantile, with the expected disease onset of less than or equal to 30 months of age, early juvenile MLD with expected disease onset more than 30 months and less than 7 years of age, juvenile MLD with disease onset more than 30 months and less than 7 years of age. Has the MLD diagnosis been confirmed with all of the following? Biochemical testing documenting ARSA activity is below the normal range for laboratory performing the test. The presence of 2 disease-causing ARSA alleles, either known or novel mutations identified on the genetic testing. If the novel mutations are identified, a 24-hour urine collection showing elevated sulfide level. Has the patient received Lenmeldi or any other gene therapy for MLD previously? Has the patient has any previous hematopoietic stem cell transplant? If the patient have received allo SSCT transplants, does the provider attest that the patient does not have the evidence of residual cells or of donor origin? Does the provider attest to the following confirmations that the autologous hematopoietic stem cell transplantations be appropriate for the patients? Infectious disease screening will be performed in accordance with the guideline, with clinical guideline priority cell collections for manufacturing. Antiretroviral medication will be discontinued at least 1 month or on the expected durations of time needed for the eliminations of the medication prior to mobilization. No vaccinations for at least 6 weeks prior to the myeloablative conditioning and until hematological recovery following treatment with Lenmeldi. Discussion about the risk of therapy, including risk of thrombosis and thromboembolic events, encephalitis, serious infections, veno-occlusive disease, and other side effects. And it's also a one-time approval dose. And this is also a high-cost drugs to us, defining at equal or more than $1 million per dose. There will be additional form that will need to be submitted for this drugs after the approval of the drugs with the prior authorization. There's a typo right there. Any comments, questions about this PK?
Okay, hearing none, no questions, then let's move on. Can we have a motion to approve the PA criteria as presented?
So move.
Thank you, Dr. Brinton. Can I get a second?
I can second. This is Laura Britton.
Thank you, Dr. Britton. And all in favor?
Aye.
Aye.
Thank you. Any opposed? Any abstentions? Thank you. Motion passes then to approve the criteria as presented. It looks like we have Dr. Huff back. And so I'd like to give the time to him for public comment at this time, if he's available.
Can you hear me now?
Yes.
Sorry about the technical difficulties on my end. So I'm just happy to, so first of all, I'm Keith Huff, health outcomes researcher on behalf of Bristol Myers Squibb, speaking today about Abecma. As you reviewed it before, it's a CAR T therapy for the treatment of adults with relapsed or refractory multiple myeloma. I'm going to present some new information today that may help. But just as a recap, Abecma's indication for relapse refractory multiple myeloma resulted from the KarMMa-3 study, the only phase 3 randomized open label pivotal trial evaluating Abecma compared to standard regimen in patients with relapsed or refractory multiple myeloma who have received 2 to 4 lines of treatment, with 100% of those patients triple class exposed, including an immunomodulating agent, a proteasome inhibitor, and an anti-CD38 monoclonal antibody. Patients who received Abecma lived 3 times longer without multiple myeloma coming back or getting worse compared to standard treatment, with a median progression-free survival of 13.8 months versus 4.4 months. And had a response rate of 71% versus standard treatment of 43%. When adjusted for crossover, overall survival was a robust 41 months for Abecma versus 23 months for standard regimen. Patients in the KarMMa-3 reported improved quality of life when taking Abecma from the beginning of the pivotal trial out to 25 months compared to standard regimen in the Global Health Status and EQ-VAS scales. In 2 real-world studies of patients in the fourth line setting, the response rate was at least 73% for 969 patients, and higher response rates were observed in patients who had not previously received BCMAs. Consistent safety with Abecma has been seen across numerous clinical trials, with most of them being low grade with early onset and short resolution. NCCN guidelines, as you know, recommend Abecma for relapse remitting multiple myeloma after 2 lines of therapy, including an IMiD, an anti-CD38, and a proteasome inhibitor. So we requested that the committee cover Abecma according to the NCCN guidelines and its indication with relapse remitting multiple myeloma after 2 lines of therapy. Thank you. Appreciate you letting me back in too.
Thank you, Dr. Huff. Any comments on that from the board? All right, hearing none, I'd like to say thank you all for your participating in this meeting today. For our next meeting, it will be March 13th, and we will continue to discuss more CAR T therapy options, prioritization criteria. And now I'd like to motion for the meeting to be adjourned.
I'll motion. Laura Britton.
Thank you, Dr. Benton. Can I get a second?
Second.
Excellent. Thank you, Dr. Pennington. All in favor? Any opposed? Thank you so much for your time today. You guys have a good Valentine weekend.
You too.
Thank you. Bye.
Make sure you